bone can be infected by hematogenous spread by direct extension from an infected joint or following trauma, surgery, or instrumentation. The formation of pus precipitates ischemia and necrosis. The central area of dead bone is known as the sequestrum. New bone, the involucrum, may form around the infection site. In children, the metaphysis of the long bones, femur, tibia, and humerus are most often involved, and infection of the spine is common in adults. Staphylococcus aureus accounts for 90% of infections. Rarer causes include Streptococcus pyogenes 4%, Haemophilus influenza 4%, Escherichia coli, Salmonella species, Mycobacterium tuberculosis, and Brucella 2%. Patients with sickle cell disease are especially prone to Salmonella infection. Patients suffering from osteomyelitis may be presented with fever and pain. In the young, pain may be poorly localized, but they may stop moving the affected limb, that is, pseudoparalysis. Later, soft tissue swelling may occur and can be followed by sinus formation. Then the pathological fractures may develop. Delayed treatment increases the risk of development of chronic osteomyelitis. Infection may develop around foreign bodies, example surgical nails or debris from trauma. Next, we have the diagnosis. How can we diagnose it? Diagnosis is clinical. The radiological changes develop late in the course of infection and may not be seen. Isotope scans indicate sites of inflammation. Fluorodeoxyglucose positron emission tomography is more sensitive. Blood cultures and pus from bone obtained through needle or open biopsy allow culture for pathogen identification and susceptibility testing. Now the question arises, how can we treat it? Drainage and excision of the sequestrum is supplemented by antibiotic therapy, example, flucloxacillin and fusidic acid. If Salmonella is isolated or suspected, ciprofloxacin may be used. Treatment lasts for 6 weeks or until there is evidence that inflammation has disappeared and the bone has healed. Next, we have the chronic osteomyelitis, which follows with inadequately treated acute infections or may be secondary to surgery or a fracture. Infection of prosthetic materials with organisms with reduced virulence, such as coagulase-negative staphylococci, is increasingly common. Staphylococcus aureus is implicated in 50% of cases. The remainder are associated with gram-negative pathogens, example, Pseudomonas, Proteus, and E. coli. Ongoing pain, swelling, deformity, or a chronically discharging sinus may be found. Culture-based diagnosis is essential. A prolonged course of appropriate antibiotics should accompany appropriate surgery. If chronic osteomyelitis occurs through infected prosthetic devices, then they may be removed.